Good morning, hello, and welcome to the Baker Institute. My name is Farhan Majid. I am the Ellie and Virginia Simmons Fellow in Health and Technology Policy at the Baker Institute, and I lead the Global Health Program here. Thank you all for coming, and thank you for the members of our Health Policy Program to support such events. We plan to have, this is the first Global Health Conference here, and we plan to have one like this every 2 years. And I'm really excited about today because, just in the general context, healthcare costs have been rising exponentially in the US, especially relative to the growth in GDP. And there's a growing interest in universal healthcare coverage in the US. But what does that mean, and how does that play out in the global context? So this conference is really for us to learn from each other, from the Canadian system, from the British system, from the German system, and from the Taiwanese system. And we have an amazing group of panel speakers today. In terms of the format, so each speaker will have about 40 minutes to speak without interruption, and then we'll have a 20-minute Q&A. In the Q&A, please feel free to raise your hands and speak through the microphone. The slides will be available after the talk on the website, so you can take advantage of that. In terms of the logistics, the women's restrooms are to my right, and the men's are to my left. You can also follow us on Twitter at Baker Health. And with that, let me just welcome our first speaker, Ms. Anita Charlesworth. She is the Director of Economics and Research at the Health Foundation in the UK, and she's going to be telling us about the sustainability and the workings of the UK healthcare system. Thank you.
Morning, everybody. It's a pleasure to be here, and it seems very fitting that, as I understand it, this is your 25th anniversary at the Baker Institute, and 2018 has been a very important year for healthcare in the UK because it's an anniversary for us. It's been the 70th anniversary of the NHS, and so we've been reflecting a lot on the experience of those 70 years, what we're proud of, and also the challenges going forward. So I'm going to talk a bit about that. But before I get into those issues, and this slide is available, I'm just going to explain a little bit about the way the National Health Service works. And the first thing to say is that the UK consists of England, Scotland, Wales, and Northern Ireland. Across all of those 4 countries of the UK, the healthcare is a single-payer, tax-funded system, but how it's organised differs slightly between the 4. So when I'm talking about organisation here, I'm focusing on England within the UK, but England is about 80% of the population and the spend. And let me see, is this a point? Oh no, oh dear, I just did something bad. So let me just, is that the pointer? Yes, hooray. So the way the English NHS works is that we pay national taxes as citizens. There are about 60 million of us. We pay our national taxes into the UK Treasury. And that Treasury determines how much should be spent on healthcare. And there is no direct relationship between the amount of tax we pay and the spending on healthcare. They're 2 actually separate decision-making processes. So taxes are set every year in the budget process, and about every 3 years we go through a process of determining how much public spending there'll be across public services, and within that how much should go on healthcare. So these are slightly separate decisions. They determine how much money to spend on healthcare, and they allocate that money to a National Department of Health and Social Care. That department then gives most of the money to a network of bodies across the country who are responsible for providing care for local populations. So it's geographically based, yeah? So you have statutory bodies that are not elected locally. They are primarily accountable to the national system, who are responsible, given a budget, and a responsibility for providing care. Yeah? Now, what care is provided is not written down. There is no national basket of goods in the UK. The intention is to provide comprehensive health care, free at the point of use, based on need and not ability to pay. But what is comprehensive is not written down anywhere. There is a body, the National Institute for Clinical Excellence, that determines for new pharmaceuticals whether they should be available. But what is within the basket is subject to custom and practice and local decisions. That network of local commissioners of healthcare give out money to family physicians, so general practitioners, we would call them. And general practitioners are, in the main, not employees of the state. They're the bit of our system which are independent contractors. So they are private, for-profit, generally speaking, small partnerships. But they hold contracts with the NHS, and for them it is the overwhelming majority of their business. We also then give money from these commissioners to maternity providers, specialist health services, acute hospitals, and mental health providers. And we do that via a national payment schedule, DRG essentially, based in the main. It's a national schedule, but with some variation to reflect the fact that cost of land, so everyone who works in here, all the doctors, are salaried employees on a national contract, but you do get some extra pay if you're in London because it's higher cost of living. So London hospitals get a bit more money, but that's all determined by this formula. And then we also have community health services. So these are things like podiatry, dietitians, nurses who go into people's homes. And again, they are funded via this national commissioning body. So that is how funding flows for the core of healthcare. The way people access services is we have a gatekeeping model, essentially. So everyone in the country is required to register with a general practitioner. Yeah? And you go and see your general practitioner for most of your care needs. If they think that you need specialist services in any way, then they refer you into this system. You have no direct access into this system other than accident and emergency departments, either via a national ambulance service or you can turn up. You do have general access to dentistry, pharmacy, and opticians. Most of these are private contractors, and there is co-pay for these services. There is no co-pay for GP services, no co-pay for any of these specialist services, and if you are prescribed a medication, 90% of people who are prescribed a medication have no co-pay. There is some element of a co-pay for people who are in work and on a reasonable income, but it raises like 1% of NHS charges. So there's very low levels of co-pay. So that's how you access the system. This is for healthcare. We also have a system for long-term care, which is what we would call in the UK social care. So these are people with primarily a social need: washing, dressing, eating. And that system is not a national tax-funded, free at the point of use system. Okay, that is funded by our local government system through a mix of local taxes and national taxes. It is severely means tested, so you have to meet a very high threshold for need, and it's needs tested and then it's means tested. So it's only available to people with very low incomes and very low assets. Yeah, and that is provided then by a network primarily of private providers. There is very little state provision and relatively little state funding as well. And then we have some public health services, which are things like smoking cessation services, drug and alcohol, which are also the responsibility of local government, and those are actually directly funded by the Department of Health. Okay, so healthcare is a very national system, tax funded, national prices, largely salaried, little co-pay. And then on the periphery of that, you have this quite complicated mixed public and private social care system. Okay. So in terms then of how much we spend, the UK spends just under 10% of GDP on health, according to the standardised OECD definition. About 80% of that is publicly funded. So it is broadly in line with the average. Here, it is obviously significantly below the US and below within Europe, France, Germany, Sweden, and also Canada. But we're pretty average in the spend in terms of share of GDP. But when you look at how much we spend per person, adjusted for living costs, we're at the low end, and that reflects the fact that GDP per head in the UK is slightly lower. And we have reasonably high input costs. So although the UK devotes a kind of average share of its wealth to healthcare, we'll have, that converts into fewer dollars, if you like, and in turn, those dollars then buy us less of the physical inputs in terms of doctors and nurses. So countries do vary quite a bit in their mix of doctors and nurses, but we're in the unfortunate group of countries that don't have very many of either. And that's a theme I'll come back to. We're also low on other physical resources like MRI scans. You can see it here, very low level of MRI scans, low level of CT scans as well. Partly, I think, reflecting the fact that in a highly politicised decision-making system, what tends to get prioritised is day-to-day running costs, and we're a capital-light system. And that has been exacerbated over recent years because if you're a politician, the pressures of today bear much more heavily than investing in the future. And that's been a systemic weakness, I think, for us. So it is 70 years of the NHS now. And one of the things that has been very striking in this anniversary is like that, I mean, the UK has gone mad for this anniversary. We have had a whole week of national television given over to celebrating the NHS. This made the Olympics opening ceremony where we had all those beds running around. Looked like a very tame event. We had a national tea party. We have really gone for it. And we've really gone for it because UK politicians would like to say that the NHS is the closest thing that the British have to religion. Yeah? So we believe in this more than we believe in anything else. Even in the week when Meghan and Harry are having a baby, you know, we are more excited about this. And in fact, when the NHS was established 70 years ago, about 75% of the population thought it was a good idea. And this year, in its 70th anniversary, 87% of the population now think it's a good idea. So actually, over those 70 years, it's become more popular, not less popular. And you can see this in the proportion who think that the NHS should be free at the point of delivery. 67% definitely, 23% probably. I mean, almost nobody says no. Yeah, should provide comprehensive services, yeah, should be primarily funded through taxation, yeah. So there's very little public appetite for a debate about this, yeah. And in one sense, the one thing it does really well is what essentially it was founded to do. It protects people against catastrophic costs and ensure they have access to a minimum level of standards. And that bit, actually, it achieves very well. So as you can see, almost nobody is spending more than 10% of their income on out-of-pocket healthcare charges. And I'm trying to understand who those people are, because it would be quite difficult to manage to do that. Very, very few people skip a consultation due to cost as well. And where it is due to cost, it'll be things like travel cost, and potential loss of earnings. This is true for healthcare. This is not true of social care that help with independent living and residential care if you need to go into a nursing home. So this is work that was done. We've been trying to work out what to do for people with these long-term care costs for about 20 years and failing. And the most recent piece of work that was commissioned by the government to think of a better way of doing this calculated lifetime costs of care for people at 65. And what it found was that about 10% of people would face lifetime care costs of £100,000. I mean, that's not that different to dollars these days. And for most people, that would be catastrophic. So we do have a problem of catastrophic care costs for long-term care. We are also, part of the reason why there's very little debate about the model for the NHS is that people are very happy with it. So this is a piece of work that Ipsos Mori did this summer, looking at 23,000 adults aged 16 to 64 across 28 countries. And I've got a few more of their slides later on. It's quite interesting. And their question here was, how would you rate the quality of healthcare that you and your family have access to in your country? And over the 28th, the UK are the happiest with the quality of healthcare. So we are, broadly speaking, happy with our system. But it's worth noting that being happy with your healthcare system does not necessarily mean that you are delivering good health outcomes. And one of the challenges that we have, I think, is we have a Department of Health and Social Care, and it's called Health, not Healthcare and Social Care. But because healthcare is so big and so nationally run, it is focused on healthcare almost to the detriment of some of that wider understanding of health and the needs of long-term care. So what you see in terms of life expectancy, again, this is looking at countries across the OECD, is this is average male life expectancy across these countries of the OECD. The UK is average on male life expectancy, but this is female life expectancy, and the UK is significantly below there. So we are far from best in class in terms of life expectancy, which is obviously at a national level, after 70 years of a free at the point of use healthcare system, points to the fact that whilst there are many advantages to a free at the point of use healthcare system, it is not a slam dunk solution to all the problems in healthcare. And perhaps more surprisingly, even than our overall life expectancy, is our inequalities within society. So this is looking at the life expectancy for the most deprived versus the least deprived. And we have a 4-year gap in life expectancy between the most and the least deprived. But if you look at healthy life expectancy, the picture is really bleak. And so we have an 18-year gap in healthy life expectancy between the most deprived and the least deprived. And our healthy life expectancy it really lag. I think those are the wrong. So here, healthy life expectancy for the most deprived is way below our retirement age, which is a real issue then for overall productivity, because you have a significant bunch of people whose health runs out before they need to be working. By quite a significant margin. So again, universal healthcare has achieved a lot in terms of access and liberated people from the fear of catastrophic cost. but it has not been a panacea to deal with inequalities in outcomes. And although people are very happy, we have a very mixed picture then when you look below those aggregates in our performance. We have poor life expectancy, as I've said. We'll have very high rates of obesity, which are probably not unrelated to our poor outcomes. Our smoking has got better. Long-term illnesses are pretty average. We do okay on diabetes and quite good blood pressure control, which probably both reflect the strengths of a GP-led system, which does provide a network of consistent basic coverage to people, and we drink in a fairly similar overall quantities to Europeans, but we binge it rather more. I'm not speaking personally, obviously. In terms then of outcomes, there are some things again which are quite interesting and might not be what you expect from a universal system. So we do poorly on cancer, although we're getting much better. And the reason why we do poorly is not because the quality of our specialist services and access to high-cost drugs is weak, which is what you might think in a socialized system would be the problem. It's actually really late diagnosis, which actually, given that we've got no cost barrier to going into the system, you think, well, that's a bit odd, isn't it? But actually, we've got the GP system, which you have to go to first, and we've got quite a culture, partly because it's free and it's under pressure with the numbers, of saying, I should only go if it's really urgent and really serious. And obviously, cancer doesn't wear a badge for early diagnosis. A lot of the things that are symptoms that you want to pick up early in cancer are fairly generic. So we've got a problem of people being diagnosed late and being diagnosed via emergency routes. So that is something that we're very exercised about, and it points to the complexity that it is much more than just funding that you need to put in place to ensure quality and ensure really meaningful access. And we have some similar issues then with stroke and heart attack, although we've been getting better, and some poor outcomes at birth. And again, too many lower socioeconomic groups not participating early enough and as intensively as you want in antenatal care. Yeah, which points to the fact that actually, healthcare doesn't exist in a bubble. What else is happening in your socioeconomic context really, really matters in this. Access, which often people talk about, is actually one of the things that the UK oddly does best at, rather than quality of outcomes. So actually, even though we've got a system under pressure, most people are seen within 4 hours of arriving at the ED, and waiting times for hip replacements, for example, are pretty average. One of our challenges as well, though, alongside those outcomes, is that we have had incredibly volatile funding growth in our system. Partly because it is such a political decision. Much more so, I think, than many other European countries. So overall, over the 70 years of the NHS, funding in the UK has grown by 3.7% a year in real terms, so higher than inflation, and that's broadly double, GDP. So healthcare spending has increased substantially as a share of GDP, but it goes up and it goes down. We have this boom and bust cycle. We had a big boom in funding in the 2000s, and we have been going through a very tough bust since the Great Recession. and we've had austerity since then. Where it takes 10 plus years to train a doctor and heaven knows how many years to build a hospital, this pattern of volatile funding, which you only know a couple of years in advance, is really difficult if you want to plan the system. And we have a lot of challenges going forward. So interestingly, although the public are incredibly supportive of the principle of the NHS, they are very fearful that in the decades to come, it won't be sustained. And part of that reflects concerns about the last few years of very limited funding growth, and part of that a recognition of just how under pressure the system is. And I'm just going to talk now about some of the factors and the real issues that I think the system is grappling with now, which I suspect are not very different to many of the issues that you are grappling with. So one is the incredibly rapid growth in patients with chronic conditions. And we've seen a growth of 50% over the last sort of 12 years. But we've seen a growth in over 200% in people with multiple chronic conditions. And we're really struggling to manage and design the services around the needs of patients with multiple chronic conditions, to do that in the out-of-hospital system so that we can pick up people earlier and avoid hospitalisation. And that is a very dominant focus of reform in our system. We've seen a big growth in hospital activity. So this is looking at use of the proportion of the population that had an admission to hospital in 97 and by 2015. And what you see is, not only have we got an ageing population, but as people hit middle age and beyond, they are much more likely now to be admitted to hospital. And this is that chronic disease position in action. So although we've got a primary care-led system, we are being pushed to spend more and more of our resource in the acute and the emergency element of the pathway, which no one thinks is a good idea, but no one can work out how to get out of. And looking forward, this problem grows and grows for us. So over the next 15 years, if I look at the UK as a whole, we're due population growth of around 6 million people. But the vast majority of those, 4.4 million, are over 65. And actually our 85 plus population grows by almost as much as the entire growth in our working age population. And there'll be other countries, I'm looking, we got Germany later, who have this to an even greater degree. So aging is kind of really upon us now, and we're not well prepared. And so we're expecting, if we roll forward our current trends in the way that we manage people, to have people with multiple chronic conditions really accounting for the bulk of our cost. And what we worry is both that it's an enormous spending pressure, but we're completely aware that we are not giving good quality at the moment. We are not managing these health conditions in a way which is either value for the taxpayer dollar or is delivering people the sort of interventions that they would want, that particularly for older people with things like dementia really avoids that long stay hospitalisation. As a result of all of this, if we carry on as is, we are projected to need 50% more hospital activity over the next 15 years, and we are not building extra hospital capacity at all, actually, to go anywhere near that. So we need to do something radically different, and we're in the middle at the moment of being commissioned by our Prime Minister to write a 10-year plan for the NHS to work out how to do something radically different. But if we're honest, we're struggling. I think we're really struggling. And so our expected that growth in the cost of care for older people is expected to continue. What that means, again, is that healthcare spending trending way above inflation or GDP is expected to continue. So all our projections are just to stand still and meet that population growth. We would need growth of around 3.3% a year over and above inflation. And if we wanted to do anything to improve healthcare, we'd need something more like 4% a year. And for social care, we need similar sums of money. And this is causing quite a lot of soul searching. And is very noticed by the public. So although the people in the UK are very happy with the quality of healthcare, they are most worried that their system is overstretched, and they are right to think that. It is undoubtedly overstretched. And the biggest issue for us, probably in that overstretched, is that we simply don't have enough healthcare workers, and particularly registered healthcare workers, doctors, nurses, and allied healthcare professionals. So what this shows is, at the moment, we have a gap. So we have a shortage of nurses of about 10%. So 1 in 10 nursing vacancies, nursing posts vacant, which causes huge problems. And our expected, what have I done with that? There we go. Our expected supply, which is the dotted green line, going forward is way below our projections of need, and we've been very reliant on international workers, and in particular EU international workers. And post-Brexit, we've got big issues about that. In fact, the number of nurses coming from the EU since we voted to leave has fallen by 96%. And a large number are going home as well. So we are in trouble on our workforce. Not only are we in trouble with the overall numbers, but we've been actually investing our money in a mix of workforce which is not the mix we say we need to tackle the healthcare issues that we face. So actually, if you look over the last 20 years, we've had a massive increase in specialists, in hospital physicians, and a decline in the number of family doctors. Very little growth in nurses as well. So we've got big change in the composition of the healthcare workforce, a move to specialisation at a time when we believe our healthcare needs demand more generalist people. And if we wanted to manage some of the issues with family physicians by skill mix change to nurses, we're in trouble because we haven't got enough of those either. The UK public as well recognises this, and they are worried that there will not be enough providers to meet their care needs, and they are right to be worried. It is a real issue. And one of our real challenges now is that one of the ways that we've managed austerity is to prioritise day-to-day spending and underinvest in the future in things like training. And we're doing this in part because healthcare spending has just, as it's increased by more than GDP, has become just a huge part of our overall public spending. So now in the UK, £1 in every 5 of the total tax take in the country goes to healthcare. So it's an enormous part of our overall public spending and tax. And that's broadly doubled since over the 70 years since the NHS was founded. But actually, the amount of tax we pay as a society has not gone up dramatically. And the reason for that was that after the war, we were spending about 10% of our GDP on defence. And what we do now is we spend 2% of our GDP on defence, just about. So we cut defence spending, and we used that to fund healthcare spending. And that actually enabled us to have our cake and eat it. So we got more and more healthcare without having to ostensibly pay more and more in tax. But we look to have reached the end of the road in terms of other bits of public spending that we could substantially cut to make headroom for healthcare. And so people are worried about quality going forward. And healthcare has been, as I said, over history and over recent years, substantially prioritised, and other areas of spending have been cut. But we can't go on doing that, so it's quite likely at the moment that we're going to have to start to put up taxes very directly linked to rising healthcare spending. And last time we did a discretionary tax increase for healthcare was in 2002. And it was very popular. It's one of the most popular acts of the government at that time. And the British aren't wild about paying tax, so that was quite surprising. But was in a period of very high growth in our economy. So the UK, to some extent, has got scope to increase tax without any obvious major economic impact, depending on the taxes it chose. So if we look at G7 and EU, our tax to GDP ratio is very low. I mean, above the US, but low. Of the EU 15, those are the 15 countries that were in the EU before the fall of the Soviet Union, we're 13th. If we funded all of the expected increases that we need over the next few years through additional taxation, we would still be 13th in terms of tax take. But this would be a big tax rise in any kind of normal sense, and comes at a time when UK wages are still below the 2008 level when the crisis hit in real terms. So people have not got a lot of room in their family budgets to afford that. So we are about to test people's commitment to the NHS in a much more real way by asking them to reach into their pockets and pay for it. They say in polling, 61% of people say that they would like to pay extra taxes, so we will see. Okay.
Thank you for a very fine talk. And perhaps I missed it early on in your discussion, but is there a private option available to the public in Great Britain or England? And if so, are those fees or costs included in your statistics?
Okay, so private healthcare is available in the UK. About 1 in 10 people have some form of private health insurance. Very, very few people use that for emergency healthcare, and very few plans cover that. So most plans in the UK would cover people for planned care, elective procedures, and a lot of them are around wait times. There is also quite a bit of out-of-pocket spend for dentistry, ophthalmology as well. And there's a reasonable amount of one-off self-pay. So a hip replacement in the UK would be maybe $8,000–9,000. So actually it's not clear that it makes sense to insure for that. If you're reasonably well off and you've got, you're going to have that when you're older, you're going to have pension and savings. So actually there's quite a bit of self-pay in that way as well. I should also say that the most hospital care that's funded by the NHS is in NHS hospitals, but you can have your surgery in a private hospital paid for by the NHS as well. And mental health services, well, quite a long tradition of voluntary sector, third sector and charitable organisations providing that care, and that again is state funded but provided privately. So the overall proportion of GDP that we spend includes the private healthcare element and the out-of-pocket pay. Yeah.
Thank you so much for that wonderfully comprehensive and balanced overview. I was particularly interested in your comment about explanation for your poor cancer outcomes, because what I expected to hear is that it was due to a shortage of specialty care and a time lag, a waiting list to get that, because that's what we mostly hear about in the United States with respect to the NHS. You said it was more due to a problem at the primary care level in terms of recognition of symptoms, and and referral. And I was wondering if that is a general structural problem for you in terms of other chronic care diseases, conditions, that is, primary care not diagnosing, because that's one of the strategies we think for dealing with the chronic care epidemic is early diagnosis and treatment. And what is, if that is a structural problem for you, what are you working on? What kind of solutions do you see? Is it more training of the GPs to identify these symptoms in people with chronic diseases earlier, make the referral, or is it more about incentivizing or expanding your specialty care?
Yeah. A really great question, and something I would say I don't think we've fully got to the bottom of. So actually, in the 2000s, at the millennium, when we got really worried that we were really lagging in outcomes for cancer, we had a national cancer plan. We put a lot of focus on the specialist cancer services. We have a very rapid system now of referral. So I had a mammogram screen in late August, which showed a result which was suspicious, and I was in the next day in a national centre for all of the follow-up checks with the ability to be biopsied if I'd needed it that day. I mean, I was fine. So we'd put a lot of effort into that end of the system, in multidisciplinary teams, in improving the skill base of oncology and all those things. And we thought, I think, that was the key to addressing this issue. But I think what we didn't think about enough was that actually you can train GPs, but if your GP service is under the amount of pressure that our service is under, with numbers declining, and our numbers are going down really quite dramatically in our GP system, GPs to manage have introduced things in a number of cases like you can only talk about one problem when you go because you've got a 10-minute consultation. Now, actually, a lot of the way these things get rid of is you go in to see the doctor, and then you mention very quietly, oh, by the way, there was a bit of blood when I went to the toilet. Is that something I should worry about? So a lot of people don't go to say there was a little bit of blood, but if they were having the wider conversation, they would raise that. The debate for us is really we don't know, I think, quite what to do about our primary care system. It is really struggling with capacity. It is the private bit of our system, and younger. We've had a feminisation of the workforce in primary care very dramatically. They don't want to work in that model anymore, and so we need to do something quite profound with primary care. We're having a bit of a debate with cancer then about whether we should have more direct access, but also you have to deal with the stoicism of the public, who kind of feel I shouldn't bother the doctor. There are certain things you should bother the doctor about.
Can you speak to the trending of wait time between primary care and specialists, and comment on how you think that correlates with health while you're waiting for that, and how that exacerbates chronicity and potentially costs?
Yeah, I mean, you don't wait very long in the UK so for cancer, you would wait less than 2 weeks. So once you're in, it all happens pretty fast. For elective procedures, you have a maximum waiting time from referral to treatment at 18 weeks. We're not meeting that for everybody at the moment. It's about 85% of people who would be seen in that time frame. And the things you're waiting for there don't have a huge impact on health outcomes. So the things where we struggle a lot more are in the ability to really, so things like the wraparound care that an older person with 4 or 5 condition needs out in the community when they are ill in the night, and the ability to offer a really effective alternative to an ambulance at that time frame. And that requires a kind of integrated network of community nursing, that social care support, and the family doctor support that we're really struggling to join up fully and make genuinely 24/7. So our problems systemically are much more in that area. And very interestingly, and then overlaid on that, we have big issues with access to mental health. Yeah? So a big access issue is mental health. Only 4 in 10 people with a diagnosable mental health condition where treatment, available treatments are likely to be helpful, have access to care. And we've seen a big change in public priorities. So we did a lot of work polling people this summer for the 70th anniversary about their priorities for improvement. And emergency wait times remain important, but mental health is the second most important area, way above wait times for planned procedures, way above children's physical health services, all the things that historically we have prioritised. And we have big commitments to shift resource to mental health, but we're really struggling to recruit the workforce. The bits of the workforce that we need doctors to go into, primary care, psychiatry, geriatric medicine, are the harder to fill. And the bits of the country we need them to go into, the more deprived areas, the more remote areas, are hard to fill.
In the U.S., we're becoming much more aware of the importance of social determinants of health, housing, transportation, food, etc. And you've got a Department of Health and Social Care, but I didn't hear a lot about it.
No.
Can you speak more about that?
Yeah, it's a huge weakness in our system. We do have so until I think it's a year ago, it was called the Department of Health, and it didn't have social care even in its title. So that kind of long-term care for older people was just buried in the system. That's now added in at least to the title, but a genuine department for public health, which has leverage over the full range of determinants, of the wider determinants of health, is really absent. And a lot of their work, when they do look at population health, is very individual risk factor based. So it is, individual programs for weight loss or smoking cessation or some alcohol. And we had an amazing review from Sir Michael Marmot that was commissioned by the government to look at our inequalities in health, which pointed very clearly to the need for action across the social determinants. But actually, in prioritising healthcare, I'll come back to my slide, up here, over the last since the Great Recession, a lot of what government has done has hit areas of spending that would be really important to wider social determinants of health, housing and education, long-term care, all being cases in point. And our Department of Health and Social Care has been very much an advocate for health care, not an effective advocate for health.
Hi, I was just curious, besides Brexit, what other significant factors or unique factors are contributing to the NHS's shortage of physicians, and what is being done to counteract that?
Okay, well, we've had a culture historically of undertraining. So we historically funded all the cost of training, and one of the weaknesses, particularly in a short-term political funding system, is you can be, the UK expression is penny wise and pound poor, so cent wise and dollar poor. So you focus on the immediate and visible cost. Oh, training is expensive, yeah? We'll limit that now. And what you don't see is the huge cost that you face a few years down the line when you haven't got enough staff, and that is really impacting on your ability to deliver care productively. So we've historically undertrained and been very reliant on international recruitment, and we flog our people really hard. We work our system really hot. Our hospital occupancy rates is over 95%. I mean, you are literally, the person is getting out of the bed when you're getting in it. In our system, it is not sustainable for people to work at that pressure. And also, I think we would argue it actually undermines long-term value, because it is very difficult to do the sort of quality improvement work around things like, whole systems flow, to think about how you manage effectively patients with chronic disease when you need to do things very differently, is if everyone is just running to stand still.
Would you speak to how you all deal with hospice care and end-of-life care, since that's going to be something that's going to really greatly increase your costs?
Yeah, a lot of people in the UK, when asked, which we do ask quite a lot, say they would like to die either at home or in a facility like a hospice. But very many more of them end up dying in hospital through an emergency admission. And we have a big gap between what people would like for end-of-life care and what people experience for end-of-life care. End-of-life care is over-medicalised and over-institutionalised. We'll have a strong and historic network of hospices which have been largely funded via charitable purposes. There is some state funding for that now. But again, I think one of the big issues that we have is that we're not well joined up. So people can have, we haven't got enough. We've got a big drive for advanced care planning. In the last phase of people's lives, to avoid those hospitalizations. For people in residential care or people who are at home having support from the social care system, they don't all have the skills base. It's very low skilled, very high, not very low skilled, very low wage. It's a very different thing. Very low wage, very high turnover, very task-contracted, fragmented system, which makes really good end-of-life care difficult. And it is something people are very unhappy about, but it is some of those systemic weaknesses in the strength of our out-of-hospital system, which I think lie at the root of a lot of that.
You mentioned, I think, 3.7% real growth above inflation for your costs. And obviously a great deal of that is due to the aging population.
Yeah.
If you normalize your numbers for aging population and just look at it on a constant basis, what percent of growth in the healthcare system is due to just increased costs for an individual? How much is due to the increased utilization for the aging?
Okay. So my rule of thumb is about a quarter of our growth has been the aging and growth in the population. About a quarter of our growth has been the fact that those people are sicker. with the rise of chronic disease, and then about half of it is rising input cost, with Balmer's cost disease. That our productivity growth does not keep pace with the growth in wages and drug prices that you need to pay. But going forward, it looks like the chronic disease is the big prize for us. It's probably bigger now than the aging effect, and it's a bit where we have a real opportunity to drive better value because we're not going to be awash with money for the foreseeable, even without Brexit.
I just have two questions. So one is related to a question on the GP versus specialist salaries.
Yeah.
And I'm wondering what's really driving the wedge between that. Like in the UK, what's really driving the wedge between the GP and the specialist salaries? Because and the second question is, what role do you think child health is playing in reducing investments in child health are playing in reducing healthcare costs?
Yeah. So in terms of the issue for GPs versus specialists is less a salary issue. Actually, our primary care salaries are pretty good, and we increased them quite sharply at the beginning of the millennium. But the model for primary care is that you're an independent contractor, you're in a small partnership, and you're an equity owner in that partnership. And what we find is increasing number of younger GPs don't want to buy into that model. Whereas if you're a hospital doctor, you're an employee of the NHS, so you're in a salaried structure and with a career structure as well. So there's an issue there. There's a sense that the primary care job is almost impossible to do it well. And so the satisfaction and the joy has gone out of the system. And then historically we've had a problem where when we've tended to train in a very hospital and centric and specialist dominated model in our big cities, and there's quite a lot of evidence that the way you train and the ethos that you train in has quite an impact in where people go. So we've just expanded the number of undergrad medical student places quite sharply, and we're opening 3 new undergraduate medical student places which are in more remote areas, and where all of the training will be much more based in out-of-hospital settings, with the aim of trying to change some of the perceptions. There's a lot going on now to consolidate primary care into bigger units, multi-specialty, to bring in federations and stuff. But I don't think anyone will claim we've cracked it. And you get into a vicious circle, you don't have enough, so the system's under pressure, so you move into something that feels much more like just a processing factory. So the things that were supposed to make primary care really rewarding, you cared for a whole family, you knew about them, you were involved in a real partnership in people's care, that goes, but that was the point that made primary care attractive in the first place. So it points to, you need to, if you want a primary care-led system, you really need to invest in primary care to enable it to be genuinely flourishing primary care,
So much. Would you please educate me a little bit about how care is rationed? Because I was under the impression it was. And second part would be how that impacts those elderly with the chronic conditions.
Yeah. So there's formal rationing and informal rationing. So like every healthcare system, care is rationed. You cannot turn up and have anything and everything that you want. We would spend 100% of GDP if we did. The formal bit in our system is that when a new drug comes to market, it is licensed in the UK, but then there is the fourth hurdle. So the National Institute for Clinical Excellence does a cost-effectiveness assessment as to whether that should be made available within the NHS, and it has a threshold, cost-effectiveness threshold. It uses a cost per quality-adjusted life year, and officially that's 20 to £30,000. It's almost certainly been moving down, and we have just altered that system so that now you have to meet that hurdle, but then if it's got a big budgetary impact, so you could be a cost-effective drug, so Hep C led to this. You'd be a cost-effective drug, but you might be a huge budget line, yeah? And historically, if you were cost-effective, you had to be, it had to be introduced. So now, then if it's cost-effective, then the Department of Health and the National Commissioners are allowed a period of time to negotiate with the industry over price, to ensure then that they get a good market access deal. So you can now take that into account, which is more like the French and many other, an Australian, I think, system where we also do a budgetary impact assessment. And we introduced Hep C then in a targeted way, so we phased it in based on a graduated assessment of ability to benefit. So in the first year, I think 10% of people who could benefit got it based on an identification of prioritisation. And we've had an almighty row about the PrEP vaccine for HIV, which has gone to court over whether that should be in and paid for through the NHS budget or as a public health measure and should be at the discretion of local government. So that can get quite fraught. We'll have greater access for cancer because a lot of cancer drugs were failing this test. So a special fund for a bit of extra access for cancer. And then you have the informal system where essentially, the GP has to decide if you need a referral. And obviously, there are guidelines in place, but that is a clinical judgment. But you can see that clinical judgments, in part, reflect perceptions of the pressure that their specialist colleagues are under, the wait times that they perceive in that. That process is very hard to precisely document, and local areas are required to balance their budgets. So we have had, it used to be, so recommended in the NHS from the NICE is that every woman under 40, every couple under 40, I think it's under 40, should get at least 2 cycles of IVF paid for by the NHS. There are a number of areas now that have reduced that to 1 or imposed further restrictions for budgetary reasons.
One more question.
Good morning. I'm sorry. Can you help me understand how the system works around pregnant women? So if I find out that I'm pregnant, I have to go to GP to confirm the pregnancy before I see maternal or OBGYN?
You can go direct access to a midwife now. So most maternity, so the difference between the UK and the US is most women don't have an OBGY consultant. So, and most maternity care is provided by midwives. So you can either go to your GP or you can go direct access to a midwife, and then you have to choose initially then at 10 weeks whether you want your care provided either to have your baby at home, to have it in a midwife-led facility or to have it in a hospital facility. Now, you can change your mind later, but you choose those pathways and you choose which provider that you want. A lot of women first time go to their GP because they don't know, that's the bit of the healthcare system they know, and then the GP says, you go here. Yeah. But with subsequent babies, women will know the midwife of their choice and tend to go there straight. Okay, thank you.